Hello everybody. Today we are going to discuss the case of community acquired pneumonia. So we have this 43-year-old female patient who was a known case of hypothyroidism obstructive sleep apnea. She presented to us with a history of fever since 4 days, cough, backache. Initially she went to Medicity Hospital, Kharghar, and then chest X-ray was taken, which was suggestive of bilateral infiltration. Then she was referred to our hospital for further treatment. So on arrival in the ER, patient was in respiratory distress, not maintaining saturation. Then they have taken chest X-ray, which showed bilateral infiltration. So by this X-ray and history, it was more pointing towards ARDS. So initially we have in emergency, she was started on the NIV support, but she was tachypneic, desaturating. Despite being on NIV, her O2 requirements were persistently high. So intubation was done, and the provisional diagnosis at that time was ARDS because all the features of this patient, high O2 requirement, by this extensive bilateral lung involvement. So the suspicion of ARDS was very high. ECG was taken, which was suggestive of sinus tachycardia. These are the investigations of this patient, which was by and large normal, except for the pro-BNP and procalcitonin. So we have sent a number of investigation because of the history of fever and these large lung patches, which was H1N1, then dengue, malaria, streptococcal urinary antigen, Legionella urinary antigen, and mycoplasma urinary antigen, out of which dengue and malaria came out to be negative. So also she was negative for H1N1 also. So this was the ABG of this patient, which showed persistent respiratory acidosis and low PF ratio. So because of the high O2 requirement, that is, she was requiring the O2 requirement of 40%. Compliance was around 30. So the prone position was given to the patient for 14 hours. We have started her on the empirical antibiotic, which includes Zoostem, then Doxy for atypical coverage. This was the CT of this patient, which showed extensive lung involvement bilaterally. So eventually, after that, after some days, she was patient was intubated at least for 4 days, and this was the fourth day of the patient. After that, urinary antigen came out to be positive for the streptococcal antigen, and we have also sent the respiratory biofire of this patient, which was also positive for the streptococcus pneumoniae. So the final diagnosis of this patient was the severity community acquired pneumonia due to streptococcus pneumoniae organism. So the same antibiotic was continued for this patient. Gradually, the patient's auto requirement came down, uh, and eventually patient got extubated on 7th day. So we'll have brief discussion on the community acquired pneumonia. Community acquired pneumonia is the acute infection of pulmonary parenchyma in patient who has acquired infection in the community. So factor that increases the risk of community acquired pneumonia include advanced age, chronic lung disease, chronic heart disease, cardiovascular disease, diabetes mellitus, malnutrition, viral respiratory tract infection, immunocompromising condition, then lifestyle factors such as smoking, excessive alcohol consumption. The development of the pneumonia is influenced by the combination of factors, including host susceptibility, pathogen virulence, and the inoculum of the microorganism reaching the lower airways. So, the respiratory pathogen must overcome several defense mechanisms of the respiratory system before reaching alveoli. So, these defenses include mucus trapping, mucociliary clearance, coughing, swallowing. And pathogen can reach the alveoli by means of microaspiration, then inhalation, macroaspiration, which consists of aspiration of large amount of oropharyngeal and upper gastrointestinal content, or hematogenous spread. Microaspiration is the primary path for microorganism into the lung, and macroaspiration may lead to aspiration pneumonia. The alveolar macrophage is the primary defense mechanism in the lung, and the lung microbe may also contribute to the defense mechanism by producing antimicrobial molecules and competing for nutrients. If pathogens overcome the alveolar defense mechanism, they will multiply and cause local tissue damage. Injured host cell then produce damage-associated molecular pattern, thus that further stimulate alveolar macrophage to produce cytokines, chemokines, and triggering local inflammatory response. Cytokines spill over the bloodstream, produces systemic inflammatory response. The local and systemic inflammatory responses contribute to the physiological response to the lung infection. The inflammatory responses explain most of the patient's sign and symptoms, as well as lab and imaging abnormalities. In some patients, the initial systemic inflammatory response can become dysregulated and result in tissue injury and eventual organ dysfunction. Numerous microorganisms can cause community-acquired pneumonia. The bacteria and viruses are considered to be likely etiological agent in all patients with community-acquired pneumonia are described as core respiratory pathogens. Severe acute respiratory syndrome, that is coronavirus SARS-CoV-2, is now the predominant viral pathogen in patients with community-acquired pneumonia. Uncommon or infrequent causes of community-acquired pneumonia should be considered as a likely agent in patients who present with the risk factor for particular pathogen, for example, travel and animal exposure. Although community-acquired pneumonia has traditionally been viewed as acute disease of the lung, the current understanding is that it is a multisystem disease that can result in acute and long-term sequelae. So the community-acquired pneumonia is associated with substantial long-term illness and death, with death at 1 year occurring in approximately 30% of all hospitalized patients and approximately 50% of the patient whose condition has resulted in admission to ICU. So these are the few examples of chest radiographs which is seen in the background history of community-acquired pneumonia. So we'll see what is CAP, what is community-acquired pneumonia, and what is severe community-acquired pneumonia. In community-acquired pneumonia, the pathological inflammatory response consists of local inflammatory response, systemic inflammatory response, which proceeds into the organ dysfunction. Then it results into the severe community-acquired pneumonia, which is occurring because of the dysregulated inflammatory response, which leads to the organ failure. Organ failure includes cardiovascular failure, respiratory failure, renal failure, neurological failure, hematological failure, metabolic and hepatic failure, and then patient with it will manifest as multi-organ dysfunction syndrome. So some clinical lab and imaging correlation is the patient will present with the cough, with sputum production, shortness of breath, pleuritic chest pain, tachypnea, dullness to percussion, rails, crackles, hypoxemia, and pulmonary infiltrate. Also with fever, chills, malaise, anorexia, tachycardia, leukocytosis, increased C-reactive protein, and increased ESR. Also, there will be confusion, hypothermia, hypotension. Lab features will show leukopenia, thrombocytopenia, uremia, hyperlactemia, increased liver enzymes, and increased creatinine. Now, the American Thoracic Society and Infectious Disease Society of America, American criteria to define severe community-acquired infection. So it divides into the major criteria, minor criteria. Major criteria include septic shock, which requires vasopressor, respiratory failure, which requires mechanical ventilation, and minor criteria include respiratory rate more than equal to 30, confusion or disorientation or both, Then hypothermia with core temperature of less than 36, hypotension requiring aggressive fluid resuscitation, leukopenia with WBC count less than 4,000, thrombocytopenia with platelet count of less than 1 lakh, uremia with the BUN level of more than 20, then a PO to FiO2 ratio of less than 250, and then multilobar infiltrate. So severe cap is defined as one major or more than or three minor criteria. Now, regarding diagnosis and evaluation, the diagnosis of community-acquired pneumonia is made on the basis of infiltrate shown on chest radiograph or on computed tomography in patient with symptoms if chest radiography is negative, plus supporting symptom sign consistent with airspace disease, for example, Rales, Ronchi, Egophone. Lab abnormalities result from the local and systemic inflammatory response. Testing for the inflammatory biomarker, like PCT, may supplement the clinical judgment with regard to diagnosis and course of the bacterial community-acquired pneumonia, since the synthesis of PCT is triggered by specific cytokine in response to bacteria. Although the PCT level is typically elevated in bacterial community-acquired pneumonia, it is low in viral community-acquired pneumonia. PCT level quickly decline with the resolution of bacterial infection, a response that can inform the decision to discontinue treatment with antimicrobial. However, procalcitonin levels are not a definite indicator, since false positive can occur, for example, in kidney injury and in hemorrhagic shock. So some bacteria may cause pneumonia in patients with normal PCT values. If access to the chest radiography is limited, diagnosis is suggested by from comprehensive examination, including evidence of lung consolidation. So community-acquired pneumonia is considered to be severe if there is manifestation of organ dysfunction or organ failure. The decision regarding site of care depend on many variables, including severity of illness, associated disease, presence of hypoxemia, adequacy of home support, probability of adherence to the treatment. The severity of the patient illness is primarily determination based on the clinical judgment, which can be supplemented by the use of severity scores. So the most commonly used scores are Pneumonia Severity Index and CUP65, a score that includes confusion, urea, respiratory rate, blood pressure, and age more than 65. So this CUP65 score scale range from the 0 to 5, and the score is calculated by assigning 1 point to the to each function, that is to each parameter, that is blood urea nitrogen level if greater than 19, then 1 point, respiratory rate greater than 30, 1 point is allotted to that. If systolic blood pressure less than 90, then 1 point, diastolic blood pressure less than 60, 1 point, age of 65 or older, 1 point. Outpatient treatment is recommended for a patient with CUP65 score of 0 to 1, short hospital stay. Close observation should be considered for a patient with score of 2, and hospitalization is recommended for patient with a score of 3 to 5. So this is the pneumonia severity index score, which consists of it consists of various components like sex, like if female, then 10 points. If nursing home resident, then 10 points. Then if there is a presence of coexisting illness like neoplastic disease, 30 points. Liver disease, 20 point. Then heart disease, 10 point. Cerebrovascular accident, 10 point. Renal disease, 10 point. Finding on the physical examination, if there is a altered mental status, 20 point, RR more than 30, 20 point, SBP less than 90, 20 point, hypothermia, presence of hypothermia 15 point, heart rate more than 125, 10 point. Then lab parameter and chest X-ray parameter, if arterial pH is less than 7.3, 30 point, BUN more than or equal to 30, 20 point, sodium less than 130, 20 point, Glucose more than or equal to 250, 10 point. Hematocrit less than 30, 10 point. PO2 less than 60, SpO2 less than 90, 10 point. Pleural effusion is present, then 10 point. So according to this, the class it is divided into five classes. So if for total points are less than 50, then to 30-day mortality is zero point 0.1. We can manage the patient on the outpatient basis. Then pneumonia severity index class 2, if total points is between 51 to 30, 30-day mortality is zero point 0.6, we can still manage the patient on outpatient basis. Then class 3 includes 71 to 90. Then 30-day mortality is zero point 0.9. So we can still manage the patient on the outpatient basis. So class 4, class 5 requires the inpatient management. And if 90 to 130, then we have to admit patient. If it is more than 30, then better to admit the patient in ICU. So this is the smart cop score. It includes systolic blood pressure less than 90. Then M is multi-lobar chest X-ray involvement. Then A is albumin less than 35. R is respiratory rate 25. Then tachycardia. T is tachycardia. C is confusion. Then oxygenation level like PO2 FiO2 ratio, and pH less than 7.3. So total point is allotted is 11. And based on smart cop score also, we can predict the mortality of the patient. So indication for the ICU care are based on the further criteria, including use of mechanical ventilation and the presence of shock. Severity score threshold has not been defined for the treatment of patients who are immunocompromised, and threshold of the admission should be based on clinical judgment. Now the next is microbiological testing. The identification of the causative agent of community-acquired pneumonia was limited in the past because there were no rapid, easily performed, accurate, cost-effective method of obtaining result for most patients at point of service. However, molecular diagnostic testing that combines sensitivity, specificity, rapid turnaround time are becoming increasingly available. So COVID-19 pandemic has illustrated the etiological importance of respiratory virus that are primarily identified by molecular testing. Molecular testing for bacterial cause is generally not recommended for most patients who are treated in ambulatory setting, since empirical antibiotic therapy is largely successful. However, testing for virus should be considered since the result can affect choice of therapy. Establishing etiologic diagnosis of community-acquired pneumonia in hospitalized patients is important for several reasons, including the appropriate selection of antibiotic for use against specific pathogen, promote good antibiotic stewardship, allow identification of pathogen associated with notifiable disease, such as SARS-CoV-2 infection and Legionnaire disease. Available recommended test includes sputum gram staining, culture, blood culture, then urine immunochromatographic analysis for Streptococcus pneumoniae, Legionella pneumophila serotype, serogroup, then molecular techniques such as multiplex assay that include SARS-CoV. In addition, if there is a risk of MRSA infection, obtain nasal swab for MRSA PCR, which can be useful since negative result can allow for discontinuation of anti-MRSA therapy. A more comprehensive microbiological workup should be performed on the basis of epidemiological exposure as well as individual patient characteristics such as immunosuppression. Now we'll see what are the sequelae of the patient with the CAB. Short-term outcome that can be occur within the 30 days includes pulmonary dysfunction, then cardiovascular dysfunction, which include arrhythmias, myocardial infarction, heart failure, then musculoskeletal dysfunction, which include generalized weakness, neurological dysfunction, which include memory loss, confusion, dysfunction of other organ like kidneys, liver, Then deterioration of the coexisting condition like COPD, heart failure, diabetes, kidney disease, and it can cause death in approximately 10 to 15% of patients 30 days after hospitalization for care. Then long-term consequences are development of a new and worsening pulmonary disease like chronic bronchitis, emphysema, development of new or worsening cardiovascular disease like stroke, myocardial infarction, arrhythmia, heart failure, development of new and worsening neurological disease, then development of new and worsening musculoskeletal disease, metabolic kidney disease, pneumonia and other infection, rehabilitation, rehospitalization, and death. So now we'll see the treatment part. Empirical antimicrobial therapy target common pathogen on the basis of risk factor. Antiviral therapy for influenza and SARS infection should be administered according to clinical factor and the result of diagnostic test or both. Therapy should be administered as soon as possible after the diagnosis of community acquired pneumonia. Now, regarding ambulatory patient, for most patients who are younger than 65 years of age, otherwise healthy and have not recently received treatment with antibiotic, recent ATS IDSA guideline recommended one of the following three oral medication options like amoxicillin, that is 1 gram 3 times daily, doxycycline 100 mg daily, or macrolide, that is azithromycin at a dose of 500 mg on day 1, then 250 mg daily, clarithromycin at a dose of 500 mg twice daily. Macrolide should be considered only in area where pneumococcal resistance to macrolide is less than 25%, which excludes the United States where resistance exceeds 30%. For patients who have taken antibiotic within the past 3 months, have serious coexisting conditions like concomitant chronic heart, lung, kidney, liver disease, diabetes mellitus, or alcohol dependence, or who are smoker, then we can start with the combination theory of therapy of amoxicillin clownate and either macrolide or doxycycline are recommended. And the patient who cannot take beta-lactam agent owing to hypersensitivity and adverse effect can instead be treated with respiratory fluoroquinolones like levofloxacin at a dose of 750 mg daily, moxifloxacin at a dose of 400 mg, or one of the two recently approved agents like lefamulin and omadacycline. Now, in hospitalized patient, the choice of appropriate antibiotic agent for treatment of patient who has been admitted to hospital is based on the presence of risk factor for MRSA and Pseudomonas. In patient admitted to the general ward without risk of MRSA Pseudomonas, combination of beta-lactam plus macrolide or doxycycline or monotherapy with the fluoroquinolone is recommended. So many observational studies have suggested that macrolide combination regimen are associated with a better clinical outcome in patients with severe community acquired pneumonia owing to the immunomodulatory effect of macrolides. Patients with severe community acquired pneumonia who are admitted to ICU are more likely at the risk of resistant pathogen, including MRSA and Pseudomonas. The establishment of etiological diagnosis is important in the treatment of this patient. So, the evidence to guide appropriate therapy in patients with severe community acquired pneumonia is limited. But common practice is to administer anti-MRSA therapy and anti-pseudomonal therapy. In patients in ICU who have shock that is being treated with vasopressor and respiratory failure that necessitate mechanical ventilation, pending results of culture and PCR test. Therapy that can modify host response like dexamethasone, interleukin 6 inhibitor, and kinase inhibitor have been established for patients with community acquired pneumonia due to SARS-CoV-2 infection. The use of glucocorticoid in the treatment of other cause of community acquired pneumonia is evolving, with recent evidence showing the benefit of survival among patients with severe community acquired pneumonia and patient at risk of respiratory failure who had been treated with hydrocortisone at dose of 200 mg daily initially followed by taper. Glucocorticoid therapy should be avoided in patients with influenza and Aspergillus pneumonia. So this is the schematic representation of treatment of community acquired pneumonia. So whether the patient is hospitalized with community acquired pneumonia or respiratory failure requiring mechanical ventilation and septic shock treated with vasopressin. If the answer for this question is yes, then it is the severe community acquired pneumonia. And if it is the answer is no, then we need to look for the presence of Pseudomonas as a cause of CAP. Uh, so if the risk factor for Pseudomonas is present, then we need to if there is a no risk factor for the Pseudomonas, then we need to see if there is any risk factor for MRSA. If there is no risk factor for MRSA, that means that if the patient is not falling under the category of severe pneumonia and the patient doesn't have any risk factor for Pseudomonas and MRSA, then the patient falls in the category of the group 1 and we can start the empirical therapy with amoxicillin ampicillin sulbactam or ceftriaxone or cefotaxime plus macrolide azithromycin, clarithromycin, or doxycycline. Or we can start the monotherapy like levofloxacin, moxifloxacin, omadacycline, and lefamulin. If there is no risk factor for Pseudomonas, but patient is having risk factor for MRSA, then this patient is falling in category 2, and we can start with beta-lactam plus a typical coverage, or for MRSA, we can add vancomycin and linezolid. If the patient doesn't have any risk factor for Pseudomonas as well as but there is no risk factor for MRSA, then for in case then empirical therapy we can add the antibiotic that will cover the Pseudomonas like piperacillin tazobactam or cefepime ceftazidime imipenem plus meropenem or macrolides like azithromycin clarithromycin doxycycline levofloxacin or moxycycline. So, and if the patient has a risk factor for Pseudomonas as well as for MRSA, and the patient is critically ill, that means the patient is requiring mechanical ventilation and vasopressor support. Then in that, then the patient is falling into the group 4, and we can start with the for this patient, we can start with piperacillin tazobactam, cefepime, ceftazidime, or imipenem, meropenem, then azithromycin, clarithromycin, doxycycline, levofloxacin, and moxifloxacin. Plus, we can give MRSA coverage like vancomycin and linezolid. Empirical therapy for hospitalized patient with community-acquired pneumonia. In the presence of severe community-acquired pneumonia with respiratory failure, necessitating mechanical ventilation and shock treated with vasopressor, initial therapy against MRSA Pseudomonas can be considered. Then pending assessment for the risk factor and subsequent microbiological test results. The strong factors for Pseudomonas include known colonization and previous infection and gram-negative bacilli on gram stain. Weak risk factor include recipient of IV antibiotic in previous 3 months, bronchiectasis, and the frequent exacerbation of COPD necessitating glucocorticoid therapy or antibiotic use. Strong risk factor for MRSA include colonization or previous infection, gram-negative cocci in clusters on gram stain. Then these weak risk factor for MRSA include recipient of IV antibiotic in previous 3 months, recent influenza-like illness, cavity infiltrate or empyema, and end-stage renal disease. In the presence of any strong risk factor, initiate empirical therapy targeting MRSA Pseudomonas aerogenes. However, in patient with a weak risk factor, the decision to initiate empirical therapy for MDR pathogen should be based on clinical judgment and individual assessment. For patients in group 1 who are receiving care in ICU unit. Combination therapy is necessary with beta-lactam plus macrolide or beta-lactam plus fluoroquinolone. The selection of anti-pseudomonal antibiotic should be made on the basis of susceptibilities of previous isolate or hospital antibiogram if available. Empirical therapy with two agents may be needed if local prevalence of drug strain is high or in patient with a history of multi-drug resistant infection. The combination of piperacillin and vancomycin has been associated with acute kidney injury, and we generally avoid this combination if possible. Recommended therapy and doses for patients with normal renal function are like ampicillin sulbactam, we can start in the dose of 3 gram IV every 6 hours, ceftriaxone 1 to 2 gram IV daily, cefotaxime 1 to 2 gram every 8 hours, azithromycin 500 mg orally IV orally daily, then clarithromycin 500 mg twice daily, clarithromycin XL to 500 mg tablet once daily, then doxycycline 100 mg orally or IV twice daily, levofloxacin 750 mg IV or orally daily, moxifloxacin 400 mg IV or orally daily. Then omadacycline 200 mg IV loading dose on day 1, followed by 100 mg daily, or 300 mg orally twice daily on day 1, or 300 mg daily. Then lefamulin 150 mg IV every 12 hourly, or 600 mg orally every 12 hours. Then vancomycin 15 to 20 mg per kg body weight IV every 8 to 12 hour or loading dose of 20 to 35 mg per kg IV, not exceed 300 mg, 3000 mg for severe cat. Subsequent dose amount should be based on area under cover values. Linezolid 600 mg IV or orally twice daily. Penicillin tazobactam 4.5 gram IV every 6 hourly. Cefepime 2 gram IV every 8 hours. Ceftazidime 2 gram IV every 8 hourly. Imipenem 500 mg IV every 6 hours. Meropenem 1 gram IV every 8 hours. Now, regarding de-escalation of antimicrobial therapy, if etiological cause of community-acquired pneumonia has been identified by means of reliable microbiological method, and there is no lab and epidemiological evidence of co-infection, treatment regimen should be simplified and directed towards pathogen. If causative pathogen is not identified, empirical treatment should be continued provided the patient's symptoms are abated. If the screening nasal swab for MRSA is negative, then empirical anti-MRSA therapy can usually be discontinued. In patients in whom viral community-acquired pneumonia is suspected, owing to the identification of virus by means of molecular test, or in whom there is no evidence of concurrent bacterial infection or clinical deterioration, antibacterial treatment can be discontinued. Most patients have some clinical improvement within 48 to 72 hours after start of antimicrobial treatment. Intravenous antibiotic regimen can be transitioned to oral regimen with similar spectral activity as patient's condition improves. So we'll see. So first is identification of the viral pathogen. If yes, and if there is if a virus, if we cannot identify virus, then we need to continue for bacterial care. If we identified bacterial pathogen, then continue with the bacterial cap only. But if we are not able to identify bacterial pathogen, then look for the radiographical evidence. If radiographical evidence are compatible with the bacterial pathogen like lobar consolidation, dense alveolar infiltrate, continue therapy for bacteria. If the radiological evidence is also not suggestive of bacterial infection, then look for the inflammatory biomarkers like WBC, CRP and PCT. If they are elevated, then most likely it is a bacterial infection. and continue like bacterial cap. If no, then consider, then look at the clinical parameter, like if there is a deterioration after 24 to 48 hour after admission, then most likely we are dealing with the bacterial cap. And if there is no, then it is a viral cap without evidence of bacterial co-infection, and we can de-escalate antibiotic for bacterial cap. Now the next is duration. Typically, patient continue to receive treatment until they have been afebrile and clinically stable condition for at least 48 hours. Treatment should continue for minimum 5 days. However, 3 day may be adequate treatment duration for certain patient whose condition is completely stable. Extended course of therapy may be indicated for patient with immunocompromised status, infection caused by certain pathogen like Pseudomonas aeruginosa, and complications such as NPAL. Serial PCT threshold as an adjunct to clinical judgment may help to guide discontinuation of antibiotic therapy. Regarding hospital discharge and follow-up, hospital discharge is appropriate when the patient is in clinically stable condition and is able to take oral medication and has safe environment for continued care. Overnight observation after switch to oral therapy is not necessary. Early discharge is based on clinical stability, and criteria for switch to oral therapy is encouraged to reduce unnecessarily hospital costs, risk associated with hospitalization. Communication and coordination with the patient's primary care clinician for early outpatient. Follow-up is encouraged to reduce the likelihood of readmission. Follow-up chest radiograph is indicated in only minority of patients, such as those at risk of lung cancer on the basis of age, smoking history, or persistence of symptoms. Prevention of smoking and excess alcohol consumption should be addressed. Vaccine against influenza, COVID-19, Streptococcus pneumoniae should be administered according to current advisory committee on immunization practice recommendations. Thank you.